Imagine walking into a restaurant, ordering dinner, and only being told the price after you finish eating. You can't leave. You can't object. You already ate. Now imagine that dinner could cost $200, or $4,000, or $40,000, and you had no way of knowing which one it would be until the check arrived. You'd call that insane. But that is exactly what happens to millions of Americans every single time they seek medical care. And the most disturbing part? The people handing you that bill aren't breaking any laws. They are operating exactly as the system was designed. Because American healthcare was never built around your ability to make an informed decision. It was built around your inability to say no. Think about the last time you needed medical care. Not routine care. Something real. Something urgent. Maybe your chest was tight. Maybe you couldn't stop the bleeding. Maybe your child had a fever that wouldn't break. In that moment, you were not thinking about cost. You were thinking about getting better. And that's exactly how the system is set up to work. Because by the time you're sitting in that exam room, the financial decision has already been made. You just don't know it yet. Weeks later, the bills arrive. Not one bill. Multiple bills. One from the hospital. One from the ER physician. One from the radiologist who read your scan. Sometimes another from the anesthesiologist. Sometimes another from the lab. Each one arrives separately, from a different company, on a different form, with a different payment portal. And the total? You had no idea it would be that high. This is not a rare experience. According to the Kaiser Family Foundation, 1 in 5 insured Americans received an unexpected bill from an out-of-network provider in just a 2-year period. 1 in 5. People who had insurance, people who thought they were covered, people who did nothing wrong. And 2/3 of all American adults say they are worried about affording a surprise medical bill for themselves or their family. This is not a fringe anxiety. This is the background noise of American financial life. Here is the core problem, and it's not the one most people think it is. We talk about healthcare costs as though the issue is that prices are too high. And yes, they are. But there is something deeper happening. Something that affects not just the size of the bill, but the entire logic of how the transaction is structured. In every normal market, price comes before purchase. You know what a car costs before you sign the loan. You know what a house costs before you make an offer. You know what a meal costs before you order it. But in healthcare, the sequence is reversed. You receive the service first. The price is determined later. And in between, you have already consented. You've already signed the forms. You've already had the procedure. There is no going back. Think about what that means. In what other market can a provider deliver a service, set the price afterward, and expect full payment, and consider that completely normal? The answer is almost none. But in healthcare, it happens every single day. And the reason it happens, the structural reason, not a moral one, reveals something profound about how this system actually works. Meet Owen. He's 34 years old. He lives in Austin, Texas. He works in project management at a mid-sized tech company. He earns around $68,000 a year. He has employer-sponsored health insurance. He pays his premiums every month. By most measures, Owen is doing fine. One afternoon, Owen is at his desk when he feels a sharp pain in his lower right abdomen. He waits. It gets worse. By evening, his wife drives him to the emergency room. The diagnosis is appendicitis. It is not optional. The appendix needs to come out that night. Owen is handed a stack of forms. He signs them. He doesn't read them carefully, not because he's careless, but because he's in pain. He's frightened, and a nurse has just told him the surgeon is ready. The surgery takes about an hour. Owen stays in the hospital for 2 nights. He goes home, He recovers. He feels relieved. 3 weeks later, the first bill arrives. It's from the hospital, $11,400. He calls his insurance company. They tell him his portion, after the deductible and co-insurance, is $3,200. He thinks, okay, that's manageable. Difficult, but manageable. Then a second bill arrives. This one is from the surgical group, $2,800. The surgeons, it turns out, are not hospital employees. They are independent contractors who bill separately. Then a third bill from an anesthesiology practice, $1,900. Then a fourth from a pathology lab that tested the removed appendix, $340. Owen stares at these 4 bills. He never chose any of these companies. He never agreed to their individual rates. He didn't even know they existed when he signed those forms in the ER. His total out-of-pocket obligation, over $5,000. From a single emergency, a single night. Owen is not a victim of fraud. He is a participant in a system that was never designed to give him information before it needed his consent. Here is the first hidden rule. In healthcare, the moment of consent and the moment of information are deliberately separated. This is not an accident. It is a structural feature. When you arrive at a hospital, especially in an emergency, the intake process is built around one goal: getting you into the system. You sign forms agreeing to be financially responsible for all charges. But the charges haven't been calculated yet. They won't be calculated until after the service has been delivered, coded, and submitted to your insurance company. And that process takes days, sometimes weeks. By then, you've already received the care. The financial commitment is already made. There's a term in behavioral economics for this dynamic: post-purchase lock-in. It's the moment when you have already committed to a course of action before you can fully evaluate its cost. Buyer's remorse is one version of this. But buyer's remorse assumes you had a choice. In an ER at 11 p.m. with appendicitis, there is no choice. There is only forward. And the system is built to use that forward motion against you. Here's a figure that makes this concrete. Researchers found that there are 4 types of hospital-based physicians: emergency doctors, anesthesiologists, radiologists, and pathologists, where patients have essentially no ability to choose their provider. They are just there, assigned, billing separately. The patient never selected them, never agreed to their rates, never had any idea they were outside their insurance network. This is the architecture of the blank check. You sign consent, you receive care. Multiple parties bill you independently, and somewhere in the middle, the total cost emerges, like a number on a lottery ticket you didn't know you bought. There is a second force that makes this even harder to navigate: urgency. Most markets allow you time. You can compare prices. You can delay a purchase. You can sleep on it. You can walk away. Healthcare strips all of that away. Not just in emergencies, though emergencies are the extreme case. Even in non-emergency situations, the window for informed decision-making is often extremely narrow. Your doctor refers you to a specialist. You call to make an appointment. You don't think to ask whether that specialist is in network. Most people don't even know that's a question they should ask. So you see the specialist. They recommend a procedure. You agree because your doctor referred them, and they seem qualified. The procedure happens. The bill arrives. And that's when you discover the specialist was out of network. Not because you were negligent, but because you were operating in a system where no one told you to ask. Here's the counterintuitive finding that stops most people cold. Nearly 1/3 of privately insured Americans received a surprise medical bill where their health plan paid less than expected in just a 2-year window. And among those people, nearly 1 in 4 got a bill from a doctor they did not expect to receive a bill from at all. Think about that. A doctor who treated you, who was present in the room, who you did not choose, billing you separately for an amount your insurance didn't cover, and you had no way to know in advance. This is not a glitch in the system. This is the system. The fragmentation, the fact that hospitals, physicians, labs, and anesthesiologists all bill independently, is not an administrative inconvenience. It is a revenue model. Each entity maximizes its own billing. No one entity is responsible for telling you the total. Let's pull back and look at the full picture. In almost every other developed country, healthcare pricing is centralized. The government negotiates prices. Patients know what things cost before they receive them. In Germany, in France, in Japan, in Canada, you don't get 4 separate bills from 4 separate companies after a surgery. You get one bill, or none. The American system is different because it was built differently. Rather than a public utility organized around patient outcomes, it evolved into a marketplace organized around billing. And billing is fragmented by design. Here is how that fragmentation works at the hospital level. A hospital is a facility. It employs nurses, manages rooms, operates equipment. But the physicians who practice inside that hospital are often not hospital employees. They are independent contractors, separate legal entities with separate billing departments. The anesthesiologist who put you under during surgery bills you directly. The radiologist who read your CT scan bills you directly. The pathologist who analyzed your tissue sample bills you directly. You never interacted with most of them. You may not even remember them. But each one has a contract. Each one has a billing code. Each one sends a separate invoice. Medicare beneficiaries see a median of 7 different providers across 4 different practices in a single year. 7 providers, 4 practices, 7 separate potential billing relationships. And each of those providers may or may not be in your insurance network. The system was not built for the patient to understand it. It was built for each provider to extract maximum payment from whatever source is available. And the patient, in the middle of it all, frightened and trusting, is the last to know. Here's the realization that changes how you see all of this. We talk about healthcare as though it is a transaction, as though you are a consumer and the hospital is a vendor, and somewhere in the process, there is a normal exchange of goods for payment. But real transactions require 2 things: information and choice. Information about what you're buying, and the genuine ability to walk away. In healthcare, you often have neither. You can't walk away from a burst appendix. You can't comparison shop for an anesthesiologist while you're unconscious. You can't negotiate price when the alternative is not getting treated. This makes healthcare unlike any other market, not because the prices are high, though they are, but because the conditions required for a market to function don't exist. And when the conditions for a market don't exist, but you structure things as though they do, one side wins. It's never the patient. There is a phrase in contract law: informed consent. It means you agreed to something with full understanding of what you were agreeing to. But in healthcare, patients routinely sign financial consent forms with no idea what the total cost will be. They are consenting to something open-ended, bottomless, a blank check with their name on it. And the system doesn't just allow this, it depends on it. Because if patients knew the total cost before they consented, if the entire bill was visible before the first form was signed, many of them would hesitate. Some would delay. Some would seek alternatives. Some would negotiate. The absence of price transparency at the moment of consent is not a flaw. It is a feature. We are taught that the free market rewards informed choices, that competition drives prices down, that transparency benefits the consumer. These ideas are true in markets where the consumer has time, information, and the ability to walk away. But when you are sick, when you are scared or in pain, or watching someone you love lying in a hospital bed, none of those conditions apply. You are not a rational economic actor in that moment. You are a human being who needs help. And the gap between those two things, between who we are told we are in the market and who we actually are in a hospital, is where the blank check gets signed. Every day, by millions of people. Not because they are naive, not because they didn't read the fine print, but because the system was built around a simple, uncomfortable truth. When the cost of not deciding is higher than the cost of the unknown, people will always choose the unknown, and the invoice will always arrive later.